Congress has just released its report on artificial intelligence, and it's a long one. Let me dive into the healthcare findings for you guys. Hi, my name is Ryan Flynn. If you don't know me, I'm a former Bloomberg biotech reporter and currently healthcare communications consultant. I work with a couple companies in the AI drug development space, so these findings are highly relevant for what I do, and I just think it's just fairly generally interesting for the overall people to understand where AI is going for healthcare. So the report came out yesterday. It's the bipartisan House Task Force report on artificial intelligence. You can find it online. It's a pretty lengthy report, over 200 pages, and about 20 of those pages are specifically related to healthcare. Now, they go over three different areas of how AI is being used and could be used, and it offers some recommendations they suggest for how to ensure that it's safe for people to use going forward. So, on the first angle or the first area is drug development and testing. The report notes that back in 2016, only one AI application was being used in drug trials. And currently, as of 2024, there are over 300 AI applications being used in drug trials. So that's obviously a huge increase. It also notes that there's 70 AI discovered drugs in clinical trials. So again, instead of humans doing research in the lab, these are drugs that were based off of targets identified by AI. Again, this is an area where I have some clients in, and it's sort of fascinating to see how they can use big data systems and large language models to potentially find new targets that might have been missed by previous human examples, and also prioritize what patients might more likely to respond to drugs in clinical trials. It's again a big area. It's very interesting, and I think we're going to see a lot more in this area going forward. I think the key thing is that in favor of AI for drug discovery and development is that there's more potential combinations of targets or areas to look at than is humanly possible to assess. And so using a large language model that can either use generative AI or more helpfully causal AI to determine cause and effect can lead to, again, potential new targets worth investigating. Where in the past we had to have a theory of what worked and try that in trials, and it's very laborious and time consuming. So, again, big area here. On the diagnostic and clinical trial decision or clinical decisions front, the report talks about how AI tools are being used to predict patient outcomes and support treatment decisions. And they also say that AI is being used to code records now. In particular, the CDC's MedCoder system automatically codes 90% of mortality records. And why this is important is because um, it allows for a quicker data scrape. So basically, before we use this system, a lot of the records came from local, health systems or government officials, government states, and by using this singular system to automatically code mortality records, it lets government officials and health officials understand, is there potentially a new threat or a virus going around or other major concerns. So the speed and accuracy is one key thing that's helpful for this particular method that CDC is using. And I mentioned on, I think, a previous video on how UC San Diego hospitals are using a different AI system to help predict and basically triage patients that might develop sepsis. It looks at different areas of readings from patients from their tests, the results, to just predictive analysis and saying this patient might develop sepsis. That might be worth giving more attention to. And it's already reduced mortality by 17% in those UC San Diego hospitals, about 50 lives a year for 2 years. So, again, really interesting and helpful way that AI is being used to just see where patients might become sick faster than normal. The third area is administrative in electronic health record use. There are two companies, Epic Systems and Oracle, which control over half the EHR market. Now, both are currently integrating tools for AI tools for note taking and scheduling. These are some of the biggest areas that a lot of physicians say lead to burnout. They spend more time filling out paperwork and scheduling and note taking than they do seeing patients. They want help with this. I think the big question is that a lot of people are asking is, great, if we use AI for these more administrative tasks, will we have more time for patients, or will we be forced to basically cram more patients in with the extra time? That is yet to be seen, but it's something you're going to see a lot of doctors and physicians talk about next year as more of these tools are being implemented. Will they be forced to see more patients with their free time, or are they allowed to spend more time with each patient, which I think will be better for most patients, and I think what a lot of physicians and clinicians want anyway. There are a couple other areas, insurance and coverage. This is interesting. So in particular, because Medicare Advantage plans have been using AI for coverage decisions, and so whether or not a patient deserves to get a treatment or not. And you'd think that this could potentially help speed things along. However, what they found was that 90% of the decisions that were AI driven, the denials were reversed on appeal. So basically, when decisions were reversed on appeal, that it became apparent that the decision was made initially by an AI system. This is raising obviously a lot of concerns. You don't want AI to say, "Hey, this person shouldn't get this treatment," and then have to fight further to get that overturned when it's made wrong. So the new CMS rule is that Medicare Advantage plans must have humans review AI coverage decisions. This is just Medicare, so not on the private sector insurance, but again, something that we'll be seeing more of next year, as I talked about in previous videos. And then just some major challenges overall. Um, the way that our healthcare system is set up in the US is that a lot of the electronic health records are siloed either with a company like Epic or with a healthcare system. And without the ability to look across the whole data set, it's hard to make really key findings that can help more patients. So the more data, the better that AI's decisions can be, but our system isn't really set up to have everything in one big database for privacy reasons, for data security reasons, and also just because there's private company considerations over it. Do they own the data? Who owns the data? I once was working with a company a few years ago that was having this debate. They made a medical machine, say an MRI machine, and they wanted to own the data that those machines generated at the hospital. The hospital said, "Well, we leased this or bought this machine from you. We should own the data." And so the question is, who owns the data in that particular instance? It's a unresolved question. The other thing when it comes to data is standardization across healthcare systems. So not all healthcare systems collect the same data, and when you don't have the same kind of fields filled out, it means that there's missing information, which again makes it harder to assess what can be best done for patients going forward. And then the other issue is bias in AI. I've mentioned this a couple different times, but there's a real issue with decisions being made in medical fields based on data that might not reflect the patient population. A lot of clinical trials, for instance, rely on mostly white men that participate in those. And so what we found in the past is that there are a lot of drugs that have been pulled off the market because we didn't know the intended impact it would have on, say, women or people of color. I think 8 of the last 10 drugs actually that have been recalled were because women reacted differently than what was shown in the clinical trials that was done mostly on men. So again, this is an important issue. We need to collect more data from various populations that aren't currently in the system. And then secondly, the other challenge is we try to make the data we collect, we try to not de-identify it. So basically removing the elements of it that will identify, let someone say hack it and identify a particular person. We want to protect people's privacy through HIPAA and other reasons. But when you remove things like race or gender, it actually makes it harder to look through how drugs may impact certain people differently. So we have to figure out how to de-identify data that allows large companies to sort through the data and find potential treatment options or clinical guidance, but not basically be able to identify people if that information is hacked or leaked. The other thing that's sort of fascinating is who is liable when AI makes mistakes. This is an issue that raised in the report. What happens when AI makes it as a clinical decision and the patient ends up having a side effect or has a horrible reaction to it? Is it the AI's fault? Is it the maker of the AI's fault? Is it the hospital that cleared the AI? These are, again, all going to be becoming much bigger issues next year. So something to keep a watch out for. And then questions on fair pay and reimbursement for AI assisted care. Again, if AI is assisting a physician with a patient care, who gets paid for that? Should there be a code to pay an AI maker for that? Should the doctor get the money? That those are all, again, unresolved issues. So the report has some recommendations. It includes just ensuring data is safe and transparent. That's also effective, maintaining research support, creating risk management guidelines, address liability issues, supporting appropriate payment systems, and improve standard monitoring. It's a really lengthy report. Check it out. It's very interesting. Hope you enjoyed this. Bye.